Hello, everyone, and welcome to the Aplastic Anemia and MDS International Foundation podcast series. We're coming to you today thanks to generous support from individuals, donors, and our corporate partners, including Celgene. My name is Tricia, and I'd like to introduce Robert Burleson, our Communications and Publications Manager.
Thank you, Tricia. When you have a serious chronic illness like any bone marrow failure disease, you may experience problems in sleeping, which may affect the success of your treatment plan. Today, we will be speaking with Dr. Asefa Mekonnen, a sleep expert who works with marrow failure patients to improve their quality of sleep and their sleep habits. Dr. Mekonnen is a pulmonologist and sleep specialist trained at Stanford University. He's the medical director of Premier Sleep Disorders Center nearby in Rockville, Maryland. He has received many awards for clinical research and frequently speaks on the subject of sleep medicine. So with that, let's get started. So, Dr. Mekonnen, let's start by asking just a very basic question. Do bone marrow failure disease patients experience sleep problems?
Yes, absolutely. In general, any patient who's diagnosed with cancer of any sort experience sleep disorder, particularly the first news of even knowing that someone has cancer creates an insomnia. Treatments that we do for any type of cancer, including bone marrow failures, the treatments also cause sleep disturbance and disruption. Pain is another component. And even the fear of the unexpected creates perpetuation of insomnia. So yes, in general, insomnia affecting about a third of the general public, but when you look into the patient population with cancer, it goes up to 60% of all.
Well, thank you. You almost anticipated our second question, which was really about what types or phases patients might be in that may have sleep problems. You mentioned newly diagnosed patients just because of anxiety, treatment-related issues, and then survivorship. You mentioned two terms, fragmented sleep and disturbed sleep. Now, when bone marrow failure disease patients come with sleep issues, what type of disorders are commonly found?
So sleep onset, sleep maintenance, insomnia are quite common. Insomnia syndrome, which would mean besides the sleep fragmentation, they experience daytime symptoms of daytime fatigue. And fatigue has significant overlap with sleep symptoms. If you look particularly also people who have bone marrow issues, through treatment or as a part of the disease, you're going to develop anemia. So anemia, especially when there is iron depletion, it's going to lead to development of restless leg syndrome, which particularly this group gets affected more frequently. Restless leg syndrome is when you have the feeling of restlessness of your legs close to bedtime, and once you fall asleep also the body goes into what we call periodic body movement, which fragments your sleep. So that we see it as the course of the anemia improves, those symptoms to improve. So those are the main ones that we see.
Thank you. You also touched on sleep disorders during the treatment phase. And of course, there's a number of treatment approaches for this group of diseases. Are certain treatments known to be worse or more drastic than others as far as how they'll disturb a patient's sleep?
Those have not been particularly studied as to which intervention would, but in general, knowing how intense any cancer treatment is, pretty much many of the medications that we use, they cause fragmentation of sleep, insomnia as a main side effect.
Thank you. And then touching back to something you'd said earlier, a patient experiences fatigue. Is there any difference in the experience, whether it's fatigue from symptoms, fatigue from treatment, or just the effect of the disease versus other conditions that they might be experiencing that would affect their sleep? Or it's sleep disturbance, plain and simple?
No, it's a combination. Fatigue plus sleepiness. Sleepiness is another factor. In fact, as we speak, I follow a patient who had bone marrow transplant and for a rare type of hematological issue, which she's on experimental treatment. One of the profound symptoms was fatigue at the beginning, which was followed by daytime sleepiness, what we call hypersomnia. So the fragmentation of sleep also followed by daytime symptom of hypersomnia. In fact, there was a study to see if the medication that we usually use to promote daytime wakefulness would help in post-chemotherapy fatigue or post-chemotherapy hypersomnia. We use it off-label and it works because it's a common symptom for patients. Another common disorder that we wouldn't touch base is obstructive sleep apnea, which in general, in the general public is common, but also because one of the symptoms is daytime sleepiness or daytime fatigue, when you develop conditions like hematological issues, if you have obstructive sleep apnea, then the symptom of daytime fatigue becomes more profound, particularly if the apnea is not treated.
Thank you. And then I guess sleep disorders can affect the quality of life for these patients to different degrees, from just minor problems to major issues with it. Is this what you've experienced, and how can patients cope with these problems?
Yes. So quality of life gets affected severely. Neurocognitive function, patient's focus, concentration, daytime daily activities are severely affected when you have untreated sleep disorder and if your quality of sleep is quite poor. Also, because it affects your immune system, as sleep fragmentation is known to affect our body's ability to fight infection, patients could be predisposed to infection through the treatment process. There is a recent interest to see if sleep fragmentation actually affects treatment outcome. Should we improve sleep, and would there be an improvement in outcome? If you look back as to what happens with sleep deprivation, the more we treat sleep, outcomes of disease significantly improve. So that's one focus that we need to do. There was a study that was done to look if survivorship centers that promote or handle cancer survivorship program, if they have incorporated sleep quality assessment. And the report was, quite poor. Only 25% of centers in the United States do look at sleep or raise the issue of sleep with their patients. So the first thing is patients should really come out and tell the physicians if they are experiencing disrupted sleep, insufficient sleep, they're waking up with headache, they have fatigue. The first thing that we do is, we assess their sleep quality clinically. They might need a sleep evaluation by testing. And if it's insomnia, the first thing that we do is what we call cognitive behavioral therapy, which is a non-pharmacological approach, and that should be the first intervention for everybody, where we use stimulus control. We teach them good sleep hygiene. Patients are trained to keep fixed wake-up time, to have bright light exposure in the morning as much as possible, to avoid things that would disrupt sleep at night, particularly caffeine, chocolate, those kind of things, alcohol, nicotine. And close to bedtime, patients are encouraged to dim light so that their own melatonin can rise up, to incorporate relaxation type of techniques. Could it be yoga or deep breathing exercise, meditation, which would enhance, the quality of sleep. If that fails, is when we will go with pharmacological intervention for sleep, for hypnotics, which usually we use it short term. So those are the main things that we do.
One other thing, if patients feel, well, I'm fatigued and I'm just going to take a nap and I'll feel better, is that okay? Or can that just compound trouble sleeping at night since they've had some sleep during the day? Is that something that's advisable or something to avoid? Yeah,
so short naps are okay if it's not too close to bedtime. Short naps by I mean is 15 minutes to half hour. Prolonged nap is not good because it's going to affect nighttime sleep. So that would be the approach.
And then later on during the recovery or well into survivorship, can they revisit napping with less concern?
Still, in general, the napping recommendation would be for short naps, 15 to 30 minutes.
Okay. Thank you. Is there a point, how can seeing a sleep specialist, people just like you, with treatment and survivorship and marrow failure, is there a point when the patient should realize it is time to get professional help and see a sleep specialist?
Yes. So the first thing is to bring it to the primary care doctor or to the nurse practitioner who's handling the primary case, and also oncologists should be informed to assess sleep quality in pretty much in each of their patients. But from patient standpoint, when symptoms of daytime fatigue is profound, when you wake up and you don't feel you have not had enough sleep, or if there's daytime sleepiness, if there's restless leg kind of symptom, then that's time to ask for a sleep medicine evaluation for a systematic approach.
Thank you. I know you may have touched on this a bit earlier in two different replies, but as it stands now, what kind of treatments, straightforward treatments, are available for marrow failure patients who are having these sleep disorder issues?
Yes. So pure insomnia, like I said, cognitive behavioral therapy, the first approach. Pharmacological intervention with hypnotic medications, the usual prescription medications for short-term use, are the two main ones. If there is restless leg symptom, then replacement of iron or pharmacological treatment with what we call dopamine agonist medications are the ones that we use. If there is sleep apnea, which it could be there, then patients are treated either with a positive air pressure or with oral appliance therapy, because sleep apnea and oxygen reduction and release of stress hormone at night definitely have been shown to affect tumor growth. So those are the evaluations that are usually interventions that are handled under the sleep specialist.
Dr. Mekonnen, I just had a thought that came while you were talking about lack of iron. What if due to transfusions and other treatments, these patients have too much iron? They often go iron chelation therapy. Is too much iron also a cause of sleep disturbances?
No. So it would be low ferritin as opposed to too much iron that would affect it.
Is it known if sleep disorders can really affect the outcome of treatment, or it's a discomfort but it's not a factor in treatment?
There are epidemiological studies in the general public and also in the oncological society. There was no breakdown in terms of the marrow failure patients, but in general, all comers from cancer, epidemiologically, people who have sleep disorders untreated, survival is less. Also in the general public, untreated sleep disorder, the longevity gets affected.
Good to know that. We have one more question just to sum up with, and that is this. What is the most important advice you can give to patients who are marrow failure disease patients in general, and specifically if they are speaking to you about problems getting regular, satisfactory sleep? What's the most important thing you would want them to know?
First is regular wake-up time. And in the morning, as soon as they wake up, they really have to be out of bed, have bright light. Morning light is very important. It assures full wakefulness. And physical stretching or physical activity in the morning. And habits that often We tend to miss habits of consuming caffeinated products after midday should be no. I mean, lifestyle issues in the morning, it's okay. Nighttime exposure to light. Now, with technologies and society now, as everybody's watching TV or on the screen or on the phone, so that light exposure affects our melatonin secretion, which actually affects sleep onset and sleep perpetuation. So for them to take it easy for about half hour before bedtime, dim light, and really make non-pharmacological interventions of relaxation, deep breathing, yoga, meditation as part of their life.
Well, thank you for some very practical things that patients can do that just on their own adjusting their own lifestyle and activities. Wanted to thank you very much, Dr. Mekonnen, for sharing your expertise and advice with the bone marrow failure disease community today. Over to you, Tricia.
Thank you so much,
Thank you for having me.
Thank you.
Thank you, Dr. Mekonnen, for being with us today. Thank you also, listeners, for being here as well. As a reminder, the AAMDSIF helpline is here for you at 800-747-2820, option 2, or email help@aamds.org, where you can be connected with Peer Support Network and other support groups. To connect with your peers online, you can join the confidential chats at marrowforums.org. And 24/7, you can find information for patients and caregivers at aamds.org. We'll see you next time. Bye-bye.